Support for this podcast comes from Bryn Mawr Communications. BMC produces a number of informative podcast series spanning a variety of topics in ophthalmology. Discover a new show at itube.net/podcasts.
Welcome, everyone, to the Four Eyes podcast, brought to you by Young OD Connect. We give you a clear view into the young optometry world across Canada and the US. And we are your hosts. I'm Dr. Amrit Bilku.
And I'm Dr. Deepan Kaur. And today we have such a lovely guest, Dr. Marcella LaBelle. Can you start by telling us a little bit more about yourself?
Sure thing. I guess the question is, how far back do you want me to go? Let's start in the early 90s, which is what my 7-year-old calls the olden days. So I was a teenager and I started off working in an optometry practice to put myself through school. And so I did every role under the sun: receptioning, dispensing, contact lens training, all the stuff you get exposure to. And included in that was some exposure to a surgery center. At the time, laser surgery was just beginning in Canada. So it was sort of the latest and greatest thing. So I got sent to the surgical center to learn how to counsel patients on surgical types. And then I put myself through school. That's how I paid for my Bachelor of Science, and then went down to Illinois College of Optometry to get my optometry degree, which I hear we're all grads of that. So that's pretty cool. So I graduated in 2002 and I started practice in primary care in a small town about an hour out of Toronto, actually. And even then I was pretty heavy into the surgical field. So we actually set up surgery days in my private care practice where we would do the testing, and we would bring in the surgical coordinator from a major Toronto laser center, and they would do their consult on the spot so that the patients wouldn't have to travel to Toronto twice. They would only have to go for the surgery. So that really sparked my interest. Yeah. And then I made my way out to Western Canada, and I started at the Gimbel Eye Center, working with Dr. Howard Gimbel. Now, I know you said your audience is mainly younger ODs, so you may not remember Dr. Gimbel's name, but if you can imagine 4 guys sitting at a restaurant table with a pen and a napkin, scribbling about the idea of putting an IOL into someone's eye, Dr. Gimbel was at that table. Okay, so he was a pioneer in cataract surgery. So I worked with him for about 13 years. And I call that my 13-year apprenticeship, because you're working with a pioneer. The stuff that I got to see was phenomenal, stuff that a regular optometrist doesn't get that opportunity to. So I really relished that experience. And then about 8 years ago, I decided it was time for a change. And so I joined Clarity Laser Vision with Dr. Ahmed El-Ghul, who is a renowned corneal specialist, cataract and refractive surgeon. So I've been there ever since. My role is to do everything but the surgery. So I counsel the patients on their surgical types. I do the calculations for surgery. Dr. El-Ghul comes in and does his surgery, and then I do the post-operative care as well. And then what's expanded in my role, which we can talk about a little bit later, is now I do the light adjustable lens adjustments. And so that's your cliffhanger for later in the podcast. So that's me in a nutshell. Basically, I've lived surgery my entire career, and I'm still going strong with it.
That's amazing. I love that you just had like so much, experience under the belt. And to work with one of the greats or like a founder in any part of optometry and ophthalmology, like that is really cool. That's something that like we, don't have the privilege to say, which is awesome. And I have a quick question, even actually before we get into the IOLs and the LALs. There are tons of students out there now and new grads that have that passion to get into a surgical role in optometry. I know in Alberta, it seems, I talked to Deepan a lot about this, and it seems like the relationship between ODs and MDs are established and a lot nicer. And so there's more opportunity, I guess, in Alberta for optometrists to work alongside surgeons. Do you have just general advice for students and young grads right now who may be interested in having that
Yeah,
surgical,
absolutely. You know
relationship?
what? That whole thing about it's not what you know, it's who you know, it
Yeah.
really applies. It's all about the networking, right? So
Okay.
you're right. We should talk about the political climate in Alberta is very favorable for optometry in general.
Hmm.
It's one of the reasons why more than 20 years ago, I made the trek across the country because if you can imagine at the time in Ontario practicing, the only medication that optometrists could dispense was Madriacil. And
Yeah.
so, having trained in the US and being certified in topical and oral medications, and I knew I wasn't practicing to my scope. So, that's a large reason why I went to Alberta.
Yeah.
So, the scope of optometry has been very favorable for optometrists in Alberta for a very long time. And there were some pioneers in ophthalmology, like Dr. Gimbel, who actually brought optometry up into a more collaborative relationship between the two. Dr. Gimbel was one of the first people actually who hired optometrists on, and he
Wow.
had them for many years. And then there was actually a change in the policy where optometrists and ophthalmologists were not actually allowed to work in the same clinic for a while. So that didn't last too long. It changed, but it's sort of been that tumultuous kind of tug and pull between the relationships. And you always think about that territorialness of,
Mhm.
are we encroaching on each other's space with the three O's, really, with opticianry as
Yeah.
well.
Mhm.
So you're right. There's a lot of more progressive attitudes in Alberta working with ophthalmology, optometry together. And so my advice to someone who wants to kind of break into that is do exactly what I did. I networked.
Mhm.
And so I actually didn't get hired on immediately. What I did was I filled in for a mat leave. And
Oh.
so it was 1 day a week. And within 3 months, I had convinced them to take me on full time.
Yeah.
So um, a big part of kind of networking is getting the ophthalmologist to know your name and to trust you. So do awesome referral letters if you're in
Mhm.
primary care, and talk and ask questions, but also come and do an observation day.
Yeah.
We are a revolving door of people coming in and watching what we do and
Yeah.
talking. And you literally get the ophthalmologist there all day so you can talk and ask questions and get to know them, establish that relationship.
Yeah.
Those type of
Right.
things, and attend the CE events. Those type of things really get you in.
That's
Yeah.
great advice. I find that
Yeah.
that can apply to any province and any state because of course
Yes.
there are certain states where the relationship with the ODMD is much stronger and that's where
Right.
you see ODs practicing to their full scope, getting
Yes.
scope expansion, modernization, and then you see other states and provinces that are really behind and just there's a lot of stubbornness there. So thank you for that. That advice
Oh, no
should really
worries.
be helpful for people looking into it.
Mhm.
And we want to dive right in. First, we
Sure.
wanted to ask you some questions and pick your brain about IOLs in general. When we think about IOLs, the first thing that comes to our mind is cataract surgery, right? You have a cataract, you got to replace it, pop in the IOL, bada bing, bada
Right.
boom, you're done. But of course, there's patients that don't have cataracts that can still be considered a candidate for IOL surgery. Do you have any advice or tips on what makes patients with no cataracts a great candidate for IOLs versus other refractive surgeries like LASIK and SMILE and PRK?
Sure. So there's a short answer and a long answer. You're going to get both from me. So the short answer is that refractive lens exchange which is what we call it when we remove a clear lens,
Hmm.
not a cataractus lens, is available to patients usually about age 45 plus who are not candidates for LASIK, PRK, SMILE, or ICL, or any other type of posterior chamber IOL that you don't remove the lens,
Hmm.
right? So that's the short answer. But to really understand the landscape of what we're looking at, we have to understand how it's changed over the last couple of decades. So the older school of thought was you don't want to remove a natural lens that's healthy,
Yeah.
Yeah.
right? Physician do no harm. And so it used to be that you were waiting until you have a clinically significant lens change.
Yeah.
You look in the eye, you see that cloudiness, the vision goes down to 20/40. And 20 years ago, we wouldn't even accept the referral for a patient who saw better than 20/40. That was like something that had to happen. They had to have a significant amount of vision loss. And so you had to wait till the cataracts were quote unquote ripe. So that generation of surgeons doing those surgeries were doing surgeries on patients on average age 65 to 80. Okay. Now, several things have changed in the last couple of decades. The first thing is the average 55-year-old patient today is not your grandma or grandpa. They have grown up in a digital world.
Yeah.
They have seen computers evolve. They are the smartphone generation. So they are used to understanding and accepting how technology evolves, risks and benefits, and they have a higher visual demand because they are using digital devices all the time. They're not just sitting in the rocking chair anymore, right? So patients are more active. And so the demand is higher on what their vision is. So patients are more educated on their options and they have a higher demand. Now, coupled with that, what has also happened in the last 15 plus years is the technology of IOLs has advanced significantly. The initial generations of lenses had a lot of downsides to them. And so a multifocal back in the 90s and early 2000s was a very simple refractive multifocal that had distance, intermediate, near rings, very crude, caused a lot of halos and starbursts and whatnot. So a lot of those lenses were actually explanted because of patient dissatisfaction. Now you fast forward several generations of multifocals, for example, and the quality of the optics has surpassed really anybody's expectations. Now we have a perceptible shift in the mindset of not just the patients, but also the surgeons. So they're now more open to accepting the younger individual because they know they can deliver the outcome that they're asking for. And so it's been so significant that it's been an entirely generational shift. So instead of having the average patient coming into our clinic being 70 years old, our average age at Clarity is 49 to 55, so a whole generation younger are seeking the IOL technology.
I get a lot of these patients in my clinic who, are roughly early 40s, early 50s. They barely have a prescription at distance. They're 20/20, but they constantly complain of not having optimal vision. They see glare, things are blurry, but you're like, you're 20/20. I don't know what to tell you here, right? And you're ruling out like corneal causes too, like dry eye or dystrophies and all that stuff. So are these kind of patients that we should be referring to your clinic to possibly consider?
Yeah, because I've had those too.
Yeah, like I've had a lot of them, and I'm just like, I don't know what is going on.
You know about ocular surface and other ocular abnormalities, and then you're looking at the lens, and it's still clear, right?
Yeah. Yes.
Yes. And so again, the technology has caught up to that. So we are now able to do what's called aberrometry, which is a measurement of higher order aberrations, right? And by being able to objectively quantify how that light behaves as it goes from front to back of the eye, we've learned something significant about that 40 to 50 age range. And that is that patients start having symptoms of dysfunctional lenses up to 10 years before you can see clinically a lens change. Okay, so this is really powerful because this validates the patient's symptomology when they're starting to lose confidence with driving at night because I feel like just aren't seeing as well. That's true because the transparency of that natural lens is losing the transmissibility of the light as it's going through years before you see it clinically. And so the ability to do aberrometry and quantify that decline in vision before it becomes a clinically significant cataract has changed the perception of many surgeons to be more open to addressing it earlier, again, because we're addressing a need that the patient has.
Yeah.
Now, I would caveat that by saying an emmetrope who is seeking freedom from reading glasses is still a tricky one. A lot of surgeons are not going to be open to doing that patient because we still have to medically justify the procedure. And usually that involves treating a refractive error. Because if you take a 45-year-old who still has a significant amount of accommodative amplitude and you remove the natural lens, I don't care what option is available, it's still going to be a net loss up close. So you have to counsel the patient accordingly. You have to balance kind of the patient symptomology versus the medical aspect of things as well, and make sure that for sure there's going to be a benefit to the patient to doing the surgery.
Yeah.
One of the things I really want to address with your listeners, especially as you're starting out in your practice, is you want to look around at who you have in your geographic location as cataract surgeons. And you need to understand what their philosophy is on surgery. So are they more old school, waiting for a cataract to develop, needing a certain visual acuity loss to accept the referral? Or are they more progressive, being more open to this younger generation? And also, what kind of implants do they offer? Because not everybody offers a premium IOL. So you'll want to understand and have potentially multiple referral sources so that you know who your patient is, right? If you get that 85-year-old with mac degen and they've worn their glasses all their life and they're not going to pay a red cent for any IOL upgrade anyway, you may have a surgeon that you're very comfortable with sending, for that bread and butter type traditional cataract surgery. But then, also your patient who is having a high visual demand, you need to know what center is open to taking a younger individual with dysfunctional lens syndrome. So you need to know your cutoffs of your surgery center. And I would say the number one thing you will want to know is whether or not your surgeon that you're going to send for premium IOLs, whether or not they have access to an excimer laser. So that might surprise you a little bit, right? We're talking corneal laser surgery now.
Yeah.
And here's why. A surgeon who has access to an excimer laser has their plan B in mind. A traditional cataract surgery, we're talking manual and make a cut, do normal phaco. We know the studies show that the percentage of patients that hit within half a diopter of their refractive target is somewhere between 58 and 72%. Okay. Now that shouldn't impress you much. That means almost 30% of patients have a residual refractive error after traditional cataract surgery.
Yeah.
So the cataract surgeon who has an excimer laser on hand is going to be able to refine that vision through a laser touch-up, right?
Okay. Yeah.
Or do they have additional technologies? So for example, at Clarity Laser Vision, we do femtosecond laser assisted cataract surgery, which means we use the laser for most of the steps of the procedure. The incision, the capsular bag placement and creation, some of the breakup of the lens. So that's going to allow more precision. So for example, it's surgically, astigmatically neutral. The incision doesn't induce some unwanted astigmatism. The capsular bag can be created more precisely and larger, which helps with IOL placement, which is particularly important for centration for multifocal IOLs. Do they use intraoperative aberrometry, which is actually using an AI platform during surgery, where in the middle of surgery, once they've removed the lens, we actually remeasure all the parameters and we get real-time feedback on how precise we're doing for the power of the implant. So if it's off, it flags it and we'll reach out into our inventory for a better lens before it goes in the eye. And the reason you want to know this stuff is it can drive that success rate up from the average about 72% to 92% of being within half a diopter of the refractive target. And in our case, 100% within 0.75 in our in-house results. So knowing how they're doing the surgery is something you as a referring physician want to evaluate. Not everybody needs that level of technology, but the ones that are looking for freedom from glasses and a premium IOL, that's what sets them up for success.
Okay.
Yeah.
Oh,
Wow, that is a
that's
lot
so
of
cool.
detail. I know.
It is.
It's funny that you mentioned all of this because in the last like 2, 3 years of all the cataract referrals I've ever made, I've collected in my head the quality of the outcomes that are coming from different centers that I've sent to. And
Yeah.
Mhm.
I have my top picks of, yeah, I know exactly what center to refer someone to if they want like the best quality outcome, really
Mhm.
good results.
Mhm.
But I didn't know any of this in the background. I've just
Yeah.
been putting two and two together. Every time
Yeah.
someone comes from clinic A, they do great. Every time someone comes from clinic B, there's a leftover prescription. They get the wrong lens put in. They get the ERM. They don't know what's happening after.
Right.
And then
And
I'm like,
in our
oh,
minds,
okay.
we're thinking, okay, that's a bad surgeon, that's a good surgeon. It honestly doesn't matter.
Yeah.
Ophthalmology is such a competitive field. If you
Yeah.
made it through and became a cataract surgeon, you are cream
You're
of the
still good.
crop.
Yeah.
Yeah.
But it's the
Oh, of course.
technology that you use to get that edge,
Right.
right?
Okay.
Yeah.
So that's why you need to know who you're sending to, what technology are they using,
Hmm.
and what is their philosophy, right?
Yeah.
Are
Mhm.
they happy with a
Yes.
0.75 refractive error?
Hmm.
Patient isn't, but
Yeah,
are they
that's
happy,
it's
right?
so
Are they going to leave it to
interesting.
you to clean it up with glasses?
Yeah.
Just last
So,
week, I had a patient who was declined
Mhm.
cataract surgery for monovision correction, but he's been in monovision contact lenses for over a decade. And I was shocked because I've sent patients for monovision correction and they've never had a problem. But this was a different surgeon that he chose to go to. And I was
mhm.
like, what do you mean he's not going to do monovision? Like, I don't get it. Now this makes sense. That's probably his philosophy of like, it's not his comfort zone to do something
Mhm.
that disrupts binocularity. So
Potentially.
that's so
And
interesting.
what's your plan B, right? Because if he doesn't
Yeah,
have access to an excimer laser and then the monovision isn't quite exactly how they target it,
yeah,
what are you going to do to correct that? Especially is that we set up an expectation for the patient to have freedom from the glasses.
yeah.
So that does bring up a good point, though. And again, your listeners, I can't emphasize how important your role is in
Mm-hmm.
Mhm.
this journey. You just alluded to the fact you knew this guy for years, you had fit him into a monovision system,
Yeah,
they liked it,
yeah.
and the surgeon disregarded that, right?
Mm-hmm.
For whatever reason, there could have been a reason,
Yeah.
right? But you know your patient.
Mhm.
And even myself, like when I do the surgical workup, that's the first time I'm seeing that patient.
Mm-hmm.
So I have 10 to 20 minutes to figure out who this person is,
Yeah.
what is their expectations, what's their lifestyle, what have they done before? All of this you guys know already,
Yeah.
right?
Mhm.
So in your referral letters, a huge clinical pearl is to put patient's been on monovision for the last 10
Mm-hmm.
years, really likes it, wants it, right?
Which is what I'm writing in the second
Yeah.
referral.
Yeah, and a second
I
referral
put
to the
that in
person who's going to be more open to doing it.
Yeah, yeah. No,
And
it's
so,
true.
but also the other peril would be like, if you know the patient is a type A personality who's
Mhm.
going to want perfection and perfection only, hey, if you could give me the heads up of that,
Yeah.
that would be
Yes.
huge because that will largely influence what implant that I recommend to the patient, right?
Yeah.
I can't
Mhm.
necessarily suss that out in the first 5 minutes of meeting the patient. So,
Yeah.
Yeah.
whatever you can put in your referral letter that gives a clue, if you
Mm.
think they're not a candidate for a multifocal, stick it in,
Yeah.
right?
Mhm.
We absolutely respect that opinion because we know you know your patient better than us.
Mm-hmm. Yeah.
So,
Support for this podcast comes from Bryn Mawr Communications. BMC produces a number of informative podcast series spanning a variety of topics in ophthalmology. Discover a new show at itube.net/podcasts.
That helps a lot. And
yeah.
we had a quick question for like clinical pearls for all of our listeners out there to know what specific type of a patient, I guess, in terms of clinical data, not just what their expectations are, for if they're eligible for like the toric, extended range, or multifocal premium IOLs. What
Sure.
makes them
Sounds
better
good.
candidates for that?
So let's not discount the expectations first, because the number one reason for dissatisfaction after an IOL surgery is unmet expectations.
Okay.
So we absolutely need to know what the patient wants, right? And we absolutely need to be explaining the goods and the bads of what we're about to offer.
Okay.
If you are doing anything other than a monofocal implant, then you are going to have some type of compromise. There is no perfect lens out there. The designs of them have advantages and disadvantages, and you have to match that up to the patient. Okay. So again, that 85-year-old with Mac DeGen who's worn glasses all their life and doesn't care about wearing glasses, you should not be trying to talk them into anything other than a monofocal lens, right? Because they're going to clean the rest of it up with glasses.
Yeah.
A monofocal lens is not an inferior lens. In fact, it's the highest quality optics out there because it's simple optics, right? So then anything beyond that, you're messing with the optics. And so we have to understand that. So we think about personality. Type A's are not going to accept any degradation of vision quality. So when we look at our multifocals, they have gotten really, really good. Let me just preface that. Despite all of that, if you have anything like a cuneiform, which is those little rings that you see in IOL, you're going to have some type of compromise to the night vision, or at least a risk of it. Yeah. And so what I explain to patients, I literally show them a picture of what rings and halos looks like around a lens. And I explain to them that about 5% of patients are going to have this permanently. Most patients are going to have some type of halos or glare for about 8 to 10 weeks, no matter what implant you choose. So you have to counsel them through that. But the 5% needs to know that we can't help them with that. Once the lens is in the eye, it's not a smart idea to go removing and replacing lenses, although it's possible. We don't like to do it. So pre-counseling the patient on that and asking them, could you live with that halo? And you show them the picture, right? And if they're like, yeah, I don't do a lot of night driving and it's worth it, I want that freedom from the reading glasses, then that's the patient I'm going to select. But I'm also going to look for ocular surface. Dry eye patients are not good multifocal patients. Okay? If you dry out, you blur out. So
I love that.
You have to optimize the ocular surface. And that's a great opportunity for the primary care optometrist to utilize their full scope and do dry eye management before they refer the patient. We love that because it does a lot of the work for us, right? If you have any macular problems, not a good idea to put a multifocal in. If they have a high angle kappa, which is something that we measure in office, we know that that means the patient will have a degraded quality of distance vision. So we have a certain cutoff where we're just not going to offer a multifocal. Okay. Previous refractive surgery is a debatable one. We have successfully done it with multifocals. But again, some of the newer options, I hope we get time to talk about light adjustables, are going to be a better option. Then we get to the extended depth of focus lenses, which there are many on the market and more coming. And there's many different designs. Some of them are being marketed as a true extended depth of focus, but they're not. They're kind of like a mini depth of focus. You need to know how the design of that lens is. But in general, those lenses allow for a bit of more forgiving optical system. And so they get good faraway vision, good intermediate, but really so near vision. So this patient's going to need to be counseled that they're going to need the reading glasses. If you sit down to read a book with an extended depth of focus lens, you're going to want to put reading glasses on for it. But the risk of halos at night goes down to about 1% or less, right? The optical quality is a little bit superior to anything with those rings, right? And so this person might choose the quality over the quantity, right? The better distance and intermediate with less range. So that's one thing to think about, okay? And then there's the light adjustable lenses, which really I want to focus on kind of talking in detail about who's a good candidate for those. So I don't know if this is a good segue.
This is the
perfect segue. So tell us more about what it is.
I got to give you the hot take on this because I think it's one of these enigmas right now in the industry where optometrists are going like, I know this is here, but I don't know, like, is it really this great thing, or is it just a glorified monovision, right?
Yeah.
So let's talk about it.
Yeah.
So light adjustable lenses, just for the audience, is an implant that is a monofocal, really out of the box, but it's made out of a silicone material that has photosensitive chemicals, macromers, within the lens. So it allows us to use UV light treatments to adjust the power of the implant after surgery. So it allows us to customize the vision to the patient's liking. Now, this has several benefits. The first one is the patient gets to try their vision out. And if they don't like it, I can troubleshoot and I can make changes without doing further surgery, right? Okay. The other benefit is the optical quality, because it's a monofocal lens. Okay, yes, there's LAL plus that's out right now, but we're really talking about the LAL lenses. And so being a monofocal lens, that means it has the optical quality of a monofocal, which is superior to a multifocal, right? So that patient that doesn't want those halos and glare, a light adjustable lens may be a more appropriate choice. Also, patient who has severe dry eye, I think was one of the questions, is going to have variability, not just in the outcome, but also in the biometry. So the refractive outcome may be a little bit more questionable, right? Or a patient who has had previous laser surgery, which affects the mathematics of calculating the implant. They may be more at risk of a refractive surprise. Or let's say a patient that has some type of suspicion of keratoconus or early changes, and we really don't want to laser that as a touch-up later on. These are all reasons to consider a light adjustable lens, because we can make those refractive changes without other surgery, right? And so it's easy enough to shift it. Now, people think about the range of vision that we can get out of a light adjustable lens. They're thinking, doesn't this just sound like monovision? Like, is it just glorified monovision? So the lens has about 3/8 diopters of asphericity within the lens, just naturally. And if I play my cards right, when I do the UV light treatments, I can actually squeeze out another 3/8 of asphericity, which allows us, just without even imbalancing the eyes, having 6 ace diopters. So it's equivalent to about 0.75 diopters of myopia, just through spherical aberration. We can get a full range of vision, distance, intermediate, and near, with less imbalance compared to a monovision. So instead of one eye being distance and one eye being near, we can make one eye distance and intermediate, because it's a range, and the other eye intermediate and near, with maybe only 1.25 diopters of myopia difference between the eyes, as opposed to what you traditionally have to do with monovision. And it's less compromised to the distance vision as well. And so the other thing I find is patients that haven't had monovision or a blended vision before, we can just give them a little baby step of it first with the first treatment, give them time to adapt to a half diopter, and they come back and they say, yes, but I want more. And then I give them another half diopter, and then they neural adapt to that. And then I give them another half diopter, bang, they're 1.5 diopters difference. And they were able to gently adapt to it as we went through the process. So we can do up to 3 refractive changes with the light adjustments. And then we have to do 2 lock-ins to lock the prescription in. Okay.
Can you reverse any of those changes too?
Absolutely. We can go more plus, more minus. The FDA says that we can do up to plus or minus 2 diopters of change, both in the sphere and the cill. I'll tell you, I've done 3.5 diopters with it. So, we can do quite a bit with it. So imagine that RK patient that it's like hard to pinpoint any refraction. We're getting stellar results with it, because we're able to really go through like a diurnal refraction, understand how the vision bounces. And then what I'm able to do is I'm able to ensure that at least one of the eyes is within kind of that plano range at a certain time of day. And so at least one eye is able to perform in distance. The patients love it because they've been used to such fluctuation, right? So yes, we can add it, we can reverse it. As you can imagine, this takes a lot of chair time. Right? So when you see the price tag of light adjustables, it's reflected in that. So
Yeah.
I do the adjustments. And so it's usually 3 to 5 visits, usually about a week apart, but every visit is 2 hours.
Wow.
Right? So my
Wow.
chair
Okay.
time with them is incredible. It's a white glove service
Okay.
because
Yes.
I refract them. I ask them what they like, what they don't like. I demo it through trial frames. We walk around, we talk about it. Then I
Mhm.
dilate, wait for them to dilate, and then we do the treatment, which is actually only about 90 seconds.
Okay.
But it's incredible work all the way up to that. And a lot of that is counseling, right?
Mhm.
Expectations, what you're going to get, what happens if I do this, right? And so it's the only lens on the market that allows us to do it. And I'm going to make a really bold statement.
Do
I've
it.
been around the block. So I've seen a lot of lenses come and go from the market, right? This lens by far has been an incredible word of mouth builder. I've never
Wow.
seen any other implant on the market that has had such a strong word of mouth referral base. My friend
Mhm.
got LALs. I want LALs, right?
Yeah.
Because the patients are so happy that they're talking about it. It's pretty incredible what can be done with this lens if you understand the optics and the
Mhm.
nuances, and it's not just monovision. So,
And
yeah.
so when these patients start to like see their regular primary care
Yes.
optometrist, will they be able to tell that it's a light adjustment lens or
Not
no?
really, because it's a monofocal.
Got
Okay.
it.
So there's
So a
nothing.
couple of things to know about this lens. You want to be refracting the patient with the lights on,
Mhm.
Okay.
not off.
Okay.
Because if you don't, then it's going to affect how that spherical aberration behaves, and you're going to way over minus the patient.
Mm.
So there are also patients that are not going to come to you at week 1 because we have to
Yeah.
hang on to them till we're finished them.
Yeah.
So you're probably not going to see them till beyond month 3, really.
Mm.
We tend to keep them until we're ready for them to kind of go back for their 1 year, like yearly visits, because there's so much counseling and the nuances of how this lens behaves, right?
Yeah.
So hopefully it just says in the letter that you get.
Yeah. And that's what
There's
I
more
was
to it.
thinking too. Like, what would
Yeah.
the follow-up be like for us who co-manage, right? Some of
Yes.
us co-manage and do the 1 week and the 1 month post-ops.
Yes.
So for LALs, it's pretty much good
It's a
luck. We'll
monofocal
see you in
lens.
a year.
Yeah.
Hope your surgeon did everything well, and then come back next year.
Thanks for propping us up.
Yeah.
Yeah. So, yeah, you just treat it like a monofocal lens because by the time the patient comes to you, they're locked in,
Yeah.
meaning there's no change available anymore on that
Mhm.
lens. So it's going to behave like a monofocal lens to you with a lot of extra asphericity as a side dish,
Got
right?
it.
We do a lot of neural adaptation counseling with these patients because it depends on how much they ended up going for, like how much of an imbalance, right?
Yeah.
Okay. That's
That is
cool.
awesome. I did not know that
Yes.
much about LALs. Yeah, you're right. When I heard about it, I was like,
Yes.
I know this is a thing, but I don't know. We'll let the
It,
surgeons figure out what you're eligible for. I don't know. Just go and then
yeah,
come
and there's a bit
back
of a
and
fear with them because it sounds like almost unbelievable.
Yeah.
So, I mean, even the patients, they shake their head. They're incredulous that in 90 seconds I've changed their vision.
yeah.
And the instrument, we nickname it the Beast. It's this big honking instrument. It's got 700,000 mirrors in it.
Okay.
Okay. And it's an AI platform that like calculates in a really specific pattern. And so the way we change that lens is inside the lens, there are macromers that react to UV light. And so we deactivate the macromers in a very specific pattern.
Mhm.
And then what happens over the next couple of days is just through, if you remember your chemistry, that diffusion gradient, the remaining active macromers migrate to even out the spaces between the molecules. And what that does is push, like Play-Doh, molds the lens into a
Got
different
it.
shape,
Yeah.
right? So
Oh,
Wow.
okay.
it's pretty sci-fi stuff. And then when we're ready for it to stop changing, we do lock-ins where we just blast a whole bunch of UV light in a refractively neutral pattern to kill off the rest of the macromers. And then
Mhm.
once that happens, it literally is just a regular IOL beyond that,
Yeah.
right? There's
And
nothing else.
Marcella, are you doing the treatments or is it
Yeah.
is it an ophthalmologist? No, you're doing
No,
the
so the
treatments.
ophthalmologist does the surgery,
And then
And then I, as the optometrist, will come in and do the rest of it, right?
Oh,
So,
okay.
yeah,
That's
I mean,
really
no
cool.
surgeon could spend that chair time.
Yeah, that's what I was going to say. I'm like, are you giving it to the
So,
ophthalmologist for like 90
absolutely.
seconds?
And honestly, I really feel optometry is best suited to do this role because I use every aspect of optometry
Yeah.
in making those decisions. It's 1,000 little decisions we make
Yeah.
when deciding how to do that UV light treatment with binocularity and understanding how the neural adaptation and the patient. That's optometry. That's not
Yes.
ophthalmology. Ophthalmology likes to fix pathology.
Yes.
And
I
so,
like to cut.
yeah, back to your listeners that are interested in OD OH relationships, light adjustable lenses are a huge foot in the door for optometry to have that relationship.
Yeah.
So in the US, there's over 600 clinics that offer LALs. When we started, we were the second clinic, first one in Alberta, and we were only the second clinic in Canada to be doing them. And now I understand there's like 14 more clinics opening up doing this stuff. That's like at least one OD per clinic that's going to be there to have a job to do these UV light treatments, which is, absolutely in the wheelhouse of optometry.
No, you're right. Honestly, for being like me, being a VT doc, I have never enjoyed listening to a conversation about IOLs more than today.
I made it exciting, right?
Yes.
It is exciting. I'm passionate about it.
I love Marcella that you just kind of like laid everything out for us because for our listeners, this is so helpful so that we get more guidance and more direction as to what candidates are good for what type of IOL or LAL when we refer them for surgery. And now I'm really going to start taking your advice. I'm going to start paying attention to what different types of surgeons offer and see if it's matching what their philosophies are, because that's something that, us as ODs, I have a different BV philosophy than other BV docs. And
there's nothing wrong with either way, right?
Exactly. And Deepon's into dry eyes and her philosophy is different than another dry eye doc. And so I just find it really cool. Just to finish off this episode, are there any other new IOL technologies on the horizon that you can give us your 2 cents on, or anything that's interesting you that's coming up in the field?
I mean, like if I take a look at where my career led, what I'm doing 25 years after graduation, I don't believe what I'm doing, right?
Yeah.
And the next 25 years are going to be the same. So I promise the technology that we do today is going to look barbaric compared to what's available 20 years from now. So some of the things that are coming down the pipeline, there's a lens called Juvene IOL, which is actually a dual optic kind of fluid filled lens. So it's not like your traditional acrylic lens. So it's supposed to behave like a young person's lens and can offer up to 3 diopters of accommodative amplitude. And what's interesting about this lens, because it's just kind of going into clinical trials in the US, is they found that there was 0 incidence of posterior capsular opacification with this lens, which was really interesting, an unusual finding to it. So that's coming down the pipeline. There's another technology called omega refractive capsule, which is a platform that you put into the capsular bag to stabilize the structure. And the benefit is that it lessens damage to the capsular bag. So you stick whatever IOL inside it, and it reduces fibrosis over time. And so the thought is, wouldn't that be cool that you can just, when new technology comes, pull out the IOL and this capsule allows you to take it out and then put another one in without having to worry about scar tissue. So that would be a big advancement in our technology as well. So I promise, I mean, this stuff that's coming down the pipeline are things that you wouldn't even think possible, right? So that's the nature of our industry. Every year, something new comes out.
Yeah. No, that's crazy. I mean, I'm glad you came on our podcast today to talk about all the stuff about light adjustable lenses, because I think Amron and I didn't know this much about it. You're right. I feel like a lot of primary care eye doctors are like, I don't really know what this is. It'll just but I
Yeah.
think this information really helped, especially the role you play in it. I had no idea. I just
Mhm.
had a question, like, how did you become certified in it, and what
Yeah.
advice would you give other ODs who want to kind of take on this
Sure.
path?
And you do need to be certified in it. So first you have to have access to the technology. So
Yeah.
typically it would be an OD that works within the surgery center. But you get hand trained by RxSight, which is the company that makes the lenses.
Okay.
And so they mentor you through it, and then they certify you once they know that
Got
you're
it.
competent in doing it. So it was kind of an interesting like add on to my skill set 23 years into practice.
Yeah.
And so it kind of rejuvenated the excitement of doing something new and
Yeah.
having kind of a hands-on influence into like how that patient is going to walk away, like what their outcome is. So definitely rewarding. And again, another opportunity for ODs to collaborate with OHs, right? So
Yes.
really good example of why it's important that those relationships get built.
Yeah. If anyone is interested in reaching out to you to see how they can get their foot in the door, how they can network with you, or if you have any other recommendations, how can people reach out to you to just talk more about it and connect with you?
That's great. Yeah. Can I put in a chat or something my email
Yes.
address? Maybe we could
Yes,
do
of
that.
course. Yep. We will
So,
put it in the description for the episode then.
and then local optometrists who are interested, we run a Facebook group called OD Collaborative.
Yes.
And so optometrists that want to refer into Clarity Laser Vision, I know you're, Deepan, you were saying like we put tidbits in there and announcements, and we do case reviews and all sorts of stuff. So it's kind of, really demystifying a lot of what we do. So I invite people to look at that Facebook group.
Thank you so much again. And thank you for coming on the podcast. And we hope you enjoy the rest of your evening.
You as well. You guys, thank you for having me. It's a subject that I love to talk about. I could do another 2 hours if you want.
Thanks for listening to Four Eyes, the podcast series brought to you by Young OD Connect. Be sure to subscribe and follow us on Instagram or YouTube at Four Eyes Optom for more content. And we'll see you guys next time. Bye.